My name is Neil Kay, and I'm pleased to be invited to talk to you today at the Lymphoma Myeloma meeting on BCR antagonists versus BCL2 antagonists, which to choose. This slide highlights the major issues that will involve my talk. I will discuss the mechanisms of action for each drug class. What is the evidence for novel agent use, primarily using data-driven phase 2 and phase 3 clinical trial results? How do we then use this data to best select agents for a clinical practice, both as single agents or combinations? And then finally, I will discuss relatively briefly the toxicity profiles for each drug class and how they impact on selection for a given patient. This figure illustrates the tremendous progress that we've made over several decades in CLL therapy. In particular, I highlight the era of targeted therapy. Today, I will be focusing primarily on 3 drugs: Ibrutinib, Venetoclax, and Acalabrutinib. Here I highlight for you the CLL main pathogenetic pathways, as well as the agents that target the BTK, PI3 kinase, and BCL2. In terms of mechanism of action, this slide illustrates the BCR BTKI antagonistic mechanism of action. On the left-hand side of the slide, you see the prototype BTKI, Ibrutinib, which targets the BTK, which is in the middle of the BCR signaling pathway. On the right-hand side of the slide, I illustrate that the Ibrutinib molecule binds to the ATP binding pocket with a specific target of cysteine 481S. In regard to the Venetoclax mechanism of action, it is currently believed that these BH3 mimetics bind to a complex of BIM, which is in turn complex to a variety of BCL2 family members. Once this interaction occurs, BIM is released and is now activated. Activated BIM in turn activates BAX and sends a series of events that result in the activation of apoptosis in a cell. We'll be using patient-based cases to illustrate our choices for therapy. So in this, our first case, a 65-year-old white male with vague symptoms, including fatigue, but no comorbid features, has adenopathy, some cytopenia with a hemoglobin of 9.5, a markedly elevated white count, and platelets of 90,000. Relevant prognostic workup includes the finding of FISH13Q, but P53 sequencing reveals no mutations. Here I give you 4 options for therapy that you might choose: Ibrutinib, rituximab, Venetoclax obinutuzumab, or Acalabrutinib. We will be using phase 2 and 3 clinical trial data to inform our decisions. To begin with, this is the schema for the RESONATE-2 study, a frontline evaluation testing Ibrutinib versus chlorambucil for previously untreated but progressive CLL. In this case, patients are randomized 1-to-1 to Ibrutinib or chlorambucil. For the Ibrutinib responders, they can continue on Ibrutinib. For the chlorambucil individuals who do not respond, they are allowed to cross over once progressive disease is established. Independent review analysis at 18.4 and 5-year follow-up time points show the superiority of Ibrutinib over chlorambucil at both time points. This is a phase 3 alliance trial, and the schema is shown for you here, where older patients with untreated CLL were randomized 1-to-1 to Ibrutinib alone, Ibrutinib and rituximab, or bendamustine and rituximab. For individuals who failed bendamustine or rituximab, they were allowed to cross over to Ibrutinib if it was within 1 year of progressive disease. The primary endpoint was PFS. I do need to point out that in this trial, 17 patients were allowed to enter the trial. The results of this trial, which is now completed, has been published in the New England Journal, and I highlight for you the outcomes in terms of PFS and overall survivorship. There is a superiority for Ibrutinib and Ibrutinib rituximab over the BR arm for PFS, but note that for overall survivorship, there is no difference between the three arms. A phase 3 ECOG E1912 study looked at Ibrutinib rituximab versus the gold standard, or prior gold standard, of fludarabine, cyclophosphamide, and rituximab for previously untreated young CLL patients. In this case, patients were randomized 2-to-1 to Ibrutinib rituximab versus the FCR. The primary endpoint was progression-free survivorship. This trial has also been completed, and the initial results published in the New England Journal and also updated at ASH 2019. And here I show you the update at ASH, where the Ibrutinib rituximab arm, the red arrow, had a superior outcome for progression-free survivorship versus FCR, and surprisingly, also for overall survivorship. So what are we to learn from these two major phase 3 trials? Both the Alliance and the ECOG study have shown us that Ibrutinib-based regimens appear to have superior clinical outcome compared to chemoimmunotherapy. I would like to also point out and highlight that the ECOG study, the E1912, has actually shown that the IR arm provides superior PFS and OS compared to FCR for previously untreated CLL. Really almost a paradigm-changing outcome. 3 points deserve mention in regard to the IR arm. 73% of the IR patients remain on treatment at a median follow-up 4 years later. Only 7% of Ibrutinib-treated patients progressed on therapy, and the patients who discontinued Ibrutinib prior to progressive disease or death did not progress for a median of 23 months after their last Ibrutinib dose. What about achieving minimal residual disease in upfront therapy? The CLL14 trial run by the German CLL study group tested Venetoclax obinutuzumab versus chlorambucil obinutuzumab. These were fixed duration regimens of 1 year. 432 patients previously untreated were randomized to these two arms. The interesting part of this cohort was that patients with significant comorbidities were eligible, with SEER scores greater than 6. The median age was 72. The primary endpoint was PFS. In the independent review at 28 months and at 40 months, the VO arm was superior to chlorambucil and obinutuzumab. In regard to undetectable MRD, less than 10 to the minus 4, both regimens showed MRD undetectable. However, the VO arm had much higher levels of undetectable MRD in both blood and marrow compared to chlorambucil obinutuzumab. What did this mean for these two arms? This figure shows you that for the two arms, if they reached MRD negativity, there was a superior PFS compared to the similar arms if they did not reach undetectable MRD. Please note that the VO arm still has an apparent superiority, even with MRD undetectable, over the chlorambucil obinutuzumab arm. I'd like to compare these results to a recent report by Ahn in the New England Journal of long-term follow-up of single-agent BTKI, that is Ibrutinib, for p53 mutated CLL. So this was an investigator-initiated phase 2 trial, relatively small trial of 34 patients with p53 mutations, treated upfront with Ibrutinib at a 6.5-year follow-up. And there are 3 key points here. 30% of the patients had a complete remission. However, there was MRD negativity in only 1 patient. The risk of progression or death in CLL patients was up to 75% lower than that with what is known for CIT. And the median time to progression was 53 months. The key point of all this is that deep remissions do not apparently are needed for prolonged responses to single-agent Ibrutinib. One other aspect I want to point out and contrast for this recent report on Ibrutinib versus Venetoclax obinutuzumab is PFS. So for the single agent ibrutinib, in this recent report, the 2-year PFS was 85% for patients with p53 mutations. This was compared to only 74% for p53 mutated patients treated with a fixed duration VO combination. What about acalabrutinib? This is the schema for the so-called ELEVATE study design, where treatment-naive CLL patients were randomized 1:1:1 to 3 arms: acalabrutinib, obinutuzumab, acalabrutinib, or obinutuzumab chlorambucil. The primary endpoint was PFS, and the median age was 70 years. 84% of these patients were greater than 65 years of age. In independent assessment of PFS and OS at a median follow-up of 28.3 months, both the acalabrutinib and the acalabrutinib obinutuzumab arm were found superior to the obinutuzumab chlorambucil arm. So at this point, I'd like to give you my summary opinion of the pros and cons of the BTKI versus Venetoclax use in frontline therapy. With respect to the BTKIs, the major pros that I would suggest is there's a longer follow-up available for these agents, particularly ibrutinib, and perhaps it is a better drug for deletion 17p TP53 mutated patients. The major contraindications for this class of agents is probably the cardiovascular complications that are known, such as hypertension and atrial fibrillation. Leading complications can be seen, particularly with ibrutinib, and it is probably important to be cautious in using these for patients with coronary artery disease and heart failure. What about Venetoclax? The major pros are higher CR rates and being able to achieve undetectable MRD at relatively high levels. It's also a time-limited therapy. What are the major cons? There is a weekly ramp-up during initiation of therapy that's required in order to prevent tumor lysis syndrome, and neutropenia and infections can be seen with this agent. So what about treatment choices for a patient? Ibrutinib appears to have 2 major positives in terms of the choice for that drug. For upfront use in progressive CLL, it appears to benefit all genetic risk cohorts over a prolonged time. While not generating high levels of MRD negativity, a durable response can still generally occur with this single agent. So reasonable choices for a patient: single agent ibrutinib would be a good choice. What about combination ibrutinib-rituximab? It is not routinely done in clinical practice. However, I would remind the audience that ibrutinib-rituximab arm in E1912 had a superior outcome for both PFS and OS compared to FCR. If MRD is a desired endpoint, the choice of Venetoclax obinutuzumab is a good one. What about acalabrutinib? This drug has been approved recently by the FDA, and this is for upfront and relapse refractory CLL based on the ELEVATE and ASCEND trial data. While there is no yet direct head-to-head comparison reported of acalabrutinib versus ibrutinib, it appears based on abstracts and selective case reports that there may be less hypertension and bleeding with this agent compared to ibrutinib. Likely it is related to the higher selectivity for BTK and less off-target effects for acalabrutinib compared to ibrutinib. Well, let's turn now to our second patient case. 55-year-old white male with fever and weight loss, no comorbid features, and again, adenopathy is prominent. Again, cytopenias with a relatively mild anemia, elevated white count, and a platelet count of 105,000. The relevant prognostic workup shows a FISH panel with 13 Q defects, no p53 mutation by sequencing. Patient has an unmutated IGHV gene, and the next-gen sequencing revealed no other abnormalities. For this patient, FCR was chosen as upfront therapy. In follow-up, after 7 years of remission, patient has now fatigue and fevers, and physical exam shows prominent adenopathy and splenomegaly. Again, cytopenias are present with a relatively obvious anemia, elevated white count, and a minimal thrombocytopenia. In this case, the prognostic workup now shows a FISH panel that's positive for both 13q and 11q minus, but again, no p53 mutation is shown by sequencing. Which therapy would you choose? I offer 4 options: Ibrutinib, Acalabrutinib, or Venetoclax, or now Adalimumab or Rituximab. Again, we're going to use clinical trial data to inform our decision. This is the schema for the so-called RESONATE trial, where Ibrutinib was compared to ofatumumab for relapse refractory CLL. Patients were randomized 1-to-1 to oral Ibrutinib at this dose or IV ofatumumab over 24 weeks. In this case, crossover to Ibrutinib could occur for ofatumumab arm if there was an IRC confirmed progressive disease. Final analysis from the RESONATE trial, which includes up to 6 years of follow-up on Ibrutinib in patients with previously treated CLL or SLL. On the left-hand side of the figure shows you, for the intent to treat, that Ibrutinib alone had a superior outcome compared to ofatumumab. On the right-hand side of the figure, you see data for the high-risk patients, that is, patients with 17p, p53, or IGHV unmutated status, where again, Ibrutinib has clear superiority for PFS compared to ofatumumab. The MURANO trial tested Venetoclax rituximab versus BR in relapsed refractory CLL. Up to 3 prior lines of therapy were possible, and this did include deletion 17p patients. Primary endpoint was PFS, and you see the randomization for 389 patients, VEN-R versus BR. The 4-year analysis for PFS in the MURANO trial is shown here. You can see that the VEN-R trial had a superior statistically significant difference compared to BR at the 4-year evaluation time point. As I mentioned earlier, the ASCEND trial design assessed Acalabrutinib for relapse refractory patients. Here, patients were randomized 1-to-1 to Acalabrutinib versus dealer's choice. In this case, Adalimumab, Rituximab, or bendamustine and rituximab. Individuals from this arm could be crossed over after confirmed progressive disease to Acalabrutinib. Again, patients could have multiple prior therapies, and the primary endpoint was PFS. PFS by independent review has now been reported by Paulo Guia and JCO, and you see that Acalabrutinib monotherapy, the median has not yet been reached using Acalabrutinib alone versus investigator choice. What about PI3 kinase inhibition drugs for relapse refractory CLL? Here in this table, I show you data for reported outcomes for duvelisib versus idelalisib in combination with rituximab. The idelalisib targets the PI3 kinase alone, whereas duvelisib targets both the delta and the gamma form of PI3 kinase. While there is important clinical positive outcome using both these agents, where the overall response is 85.5% and 73.8%, and the median OS has not been reached for the duvelisib, but is in the 40 to 35, 34.6 month range for the idelalisib. There are some disappointing features, including very low complete response rates, and also the array of complex AEs. So in the idelalisib trials, there was diarrhea, pneumonia, pyrexia, fatigue, rash, cough, and some nausea. And in the duvelisib trials, again, an array of, albeit low grade, diarrhea, neutropenia, rash, pyrexia, cough, nausea, musculoskeletal pain, and some anemia. So which therapy would you choose? I would put to you that Ibrutinib would be a very reasonable choice, as would Acalabrutinib. I think also Venetoclax with rituximab, based on the MURANO trial, would be a reasonable choice. Idelalisib rituximab would likely be a lesser choice. It's not currently in common use due to some of the array of toxicities I pointed out to you. In addition, because of the significant hepatic toxicities in upfront CLL recently reported by Lamson, it is not used in upfront CLL. Let's look at another scenario for a patient. What if this patient had, instead of FCR, prior BTKIs? What if the patient had prior Ibrutinib and you now saw progression? If there was prior Ibrutinib resistance, agents like Acalabrutinib or Zanubrutinib, a newer agent now being tested, this would not be recommended due to the identical mechanisms of action. However, novel agents could be used if clinical trials were available, but I would suggest that Venetoclax or Venetoclax rituximab would be an obvious choice. What are options for patients treated with first-gen agents, BTKI agents, and where there is obvious drug resistance? There are some next-generation BTKIs that have been developed and are being tested. These agents are listed here. These do not bind to C481S in a covalent way. They are reversible. The most prominent of which are listed here: LOXO 305 and ARQ 531 and Venetoclax. Excuse me. Venetoclax is now no longer in testing due to some disappointing results in early phase 1 and 2 trial testing. LOXO 305 and ARQ do show some promise and are in early phase 2 testing. What if the patient was intolerant to Ibrutinib? What about Acalabrutinib as a choice? There is a report by Awan at ASH in 2019 where they enrolled 33 patients. 21 patients did not experience a recurrence of Ibrutinib-related AEs during subsequent treatment with Acalabrutinib. 12 patients, or 36%, did have a persistent AE, but note that 47% decreased in severity while 41% remained stable. Other outcomes of note: 79% of the patients who were switched to Acalabrutinib, 79% had a response, and 81% had a response lasting greater than 12 months. Somewhat concerning was the apparent higher frequency of development of C481 mutation long term. This is possibly due to the repetitive exposure to these similar BTKIs. What if there is progression on Venetoclax? There's really little clinical trial data on what to choose. There's no clear consensus yet. If a patient has had a very durable response and MRD negative status, I would put to you that it would, if the patient has been discontinued and then relapsed, it would be a reasonable choice to use Venetoclax again. If there was not a good Venetoclax response and patients did not reach an MRD negative status, there is real-world data and some current small studies suggesting that the choice of a BTKI would be reasonable and that your patient would get a response to that subsequent drug. So I'd like to just summarize the toxicity profiles that I think are important to consider in choosing a BCL2 drug versus the BCR agents. In terms of the BCL2 inhibition, we have to be concerned about the possibility of a tumor lysis syndrome, although with the ramp-up protocols, these are lesser events. Neutropenia is something to be concerned about, and accompanying infections. Special issue is that for patients with cardiac disease and or anticoagulation, this might be the best choice for your patient. In regard to BCR inhibitors, there is the constellation of toxicities that one needs to take into account. These include rash, arthralgias, atrial fibrillation, hypertension, headaches, and diarrhea. In addition, I point out that for advancing age patients with comorbidities, there is a suggestion that Acalabrutinib may be the best choice. Again, there has been no report yet of head-to-head comparisons between Acalabrutinib and Ibrutinib, but there appears to be lesser impact on the incidence of atrial fibrillation, hypertension, and bleeding. I thank you for your attention.